Vishweshwar Bhatt couple on the 25th of February 1959, Sir finished his early schooling from Basrikatte village near Sringeri in Chikmagalur district. Being a meritorious graduate of Mysore Medical College, he cleared his MBBS in the year 1981. Later served in Army Medical Corps as the medical officer in the rank of captain at many military hospitals across the country and at border outposts in Poonch and other districts of other sectors of Jammu and Kashmir. He is a veteran decorated with Sainya Seva Medal. He then did his Masters in General Surgery from Bangalore Medical College in the year 1991 and was awarded the University Gold Medal. He is also a fellow of many surgical organizations. From the year 1992, Dr. Shivaram Sir has quickly and steadily worked his way up the surgical ladder to become regarded as one of Bangalore's safe surgical hands and a good academician of our country. His special interests have been in gastrointestinal and pancreatic surgery, and he has attended numerous training at several international centers, including the Sloan Kettering Memorial Hospital at New York. He is one of the pioneers in laparoscopic surgery in the early 1990s in our country. As an extension of his skills in GI and laparoscopic surgery, he is trained in bariatric and metabolic surgery and started the first such department at Columbia Asia Referral Hospital, Yashwantpur in Bangalore, and later at Aster CMI Hospital. He is an instructor, guide and examiner for surgery postgraduate students for the DNB stream and RGOHS fellowship programs. Dr. Shivaram Sir has a bowl full of surgical service.
Good evening, everybody. Thank you very much for staying for this oration lecture. Thank you, Dr. C.G. Narasimhan, being the senior most surgeon of our fraternity, being here to bless us, and thank you very much for your kind words. I thank the organizers, the Department of Anatomy, headed by none other than Dr. D.C. Purnima, for this opportunity and also a great honor to deliver this oration. So when we were thinking about the topic, so this relevance of anatomy in my profession and passion came out. Actually the passion was suggested by Dr. Dinesh because only surgery may become boring for some of the people. So anatomy is the pillar. It's the pillar of strength for all of us who become doctors. Not only for surgeons, it is the cornerstone of medical education. Every medical's first day starts with anatomy class, as we all started. My first day was, I remember, entering there and sitting in the dissection bench that was number 10. So such memories can never be erased in the doctor's mind wherever they are. As Dr. C.G.N. put it, anatomy is basic for physical examination, interpretation of symptoms and radiology like X-ray, CT, MRI, PET CT or whatever it is. And most importantly, performing surgical procedures. All of you know William Harvey. See, learning anatomy without dissection, cadaver dissection, is like learning swimming without going to water. So it's very important that you students are here, you give full attention while you are in the dissection class, because it is going to be staying with you lifelong. Wherever you go, you will remember your anatomy teachers, the cadaver you dissected, where you are sitting in the cadaver dissection bench, everything will be there. We must remember the most devoted person for anatomy, that is Professor Kanta Madam. We were all very lucky to to have her guidance. And when we entered this hall, we were all teenagers. And she's the one, like a mother, nurtured us, guided us, and brought us forward. Professor C.V. Murthy, a great surgeon, and actually he saved me and he operated me, and I can never forget about him. Professor C. Vittal, he was my guide and teacher when I was doing MS General Surgery at Bangalore Medical College. Dr. M.G. Bhatt is the one who helped me a lot after my MS to establish practice and taught the practical points about surgery. Dr. Malfobi and Dr. Rutledge are the surgeons in the US whom I cannot forget, because all my bariatric surgery and metabolic surgery was guided by them and taught by them. And to come up in the profession, we need a strong family, and that's what my daughters and son-in-laws supported me, and my youngest brother and sister-in-law who nurtured me and brought up in the family. And my wife, wherever she is, I'm sure she will be watching all this. Profession, when you make it as a passion, then you have no bounds. You will have to succeed. So like that, if the surgery is your passion, then there is no way to hold back. You will definitely succeed. But don't go behind money, but go behind your profession and your patient and make it a passion. Surgery was my passion, like GI surgery, pancreatic surgery, bariatric and metabolic surgery. The other passions, I must say that trekking, traveling, fitness, and of course, cooking. When we learn anatomy, we learn from top to bottom everything, every organ in the body, every bone, every nerve, every artery, everything. But when we go to the specialization, we go into some field which is passionate about you. So I chose the surgery, and in that mainly the GI surgery. So the abdominal wall anatomy was very, very important to me. So if you see here in the abdomen, there is very strong posterior support. Not only muscles, bony structure also. But in the anterior, it's only the ligament in the middle and muscles and these oblique muscles. This anatomy, all of you know, and there is excellent nerve supply, blood supply, and this midline, if you disrupt, then it can cause problems, because the support anterior is not that good as in the posterior. So many hernias we see, many of them can be done laparoscopically, some of them require open surgery, but the anatomical knowledge is very, very important. Here we are going through the midline and releasing all the adhesions which are there, protecting the viscera, and then dissect the posterior rectus sheath from the anterior rectus sheath. In between you see the rectus abdominis muscle. And it's very important that you should not damage any vascular supply or the nerve supply. So those are the nerves which we should identify and then protect them, should not damage. After that, you close the posterior wall, posterior rectus sheath along with peritoneum, then you put a mesh and then you put a drain. Mesh is to reconstruct and strengthen the abdominal wall and then close the anterior rectus sheath. So this knowledge of anatomy, what you learn in this hall, is the one which is going to help us when you do such surgeries and help the patient. But this is not the case in all the hernias. Many of them come late. They will have almost like a second abdomen. There is loss of domain. The viscera is sitting outside, and if you, like in the previous case, if you do surgery, it will not take up. So first thing is you have to understand that there is anatomical disruption, viscera is outside the abdominal wall, and if you put it back, they will develop cardiorespiratory embarrassment, they will go to ventilator, and some of them may not come back. So first thing is to increase the abdominal wall capacity by doing what is known as the pre-operative pneumoperitoneum, or sometimes we inject Botox also. In the pre-operative pneumoperitoneum, we put a catheter to the abdominal cavity under the ultrasound guidance and then daily inject to about 800 to 1000 ml of air so that the abdominal cavity or capacity improves. So how do you know it has improved? Then after 2 weeks or so, you do a CT scan, then you see that whatever was outside has all gone inside. The capacity of the abdominal wall is inside. That's the time we have to take the patient for surgery, and then you do what is known as posterior compartment separation or transverse abdominis release. Put a large mesh, maybe sometimes we put 50 by 50 centimeter mesh, and then close the abdomen. So that is the one which can help these patients. So what I have to say is abdominal wall anatomy knowledge is very, very important. This structure, students, you recognize? What is this? Cubital fossa base. There are very, very important structures here. We have brachial artery, nerve, biceps, radial nerve, everything. So, if this area gets crushed, what happens? It will injure the brachial nerve, median nerve, and the hand and forearm may go for ischemia. And that's what happened to me when I was doing the internship in this hospital, and when I was carrying a bottle of blood between the pathology block and the pediatric block which was ordered by Professor Anke Gowda, the pediatrician that time. A horse came back from behind and it chased me and caught my right hand from behind. So for about 10-15 minutes it didn't leave. My hand, forearm, everything became blue and numb, and you know why? Because of this anatomy. It was Professor C.B. Murthy who immediately took me surgery and released the artery and put pepperine over that, and the spasm came out and the limb was saved, and that's all destiny. And so that was a great incident which happened, and luckily I was destined to become a surgeon. But after the operation and everything, this was more painful than undergoing surgery, because in those days there was no Rabipur or other better vaccine. I had to take the vaccine to the abdominal wall every day for 14 days. So that was the incident which I cannot forget, like my alma mater. Knowledge of anatomy is only a dead weight if we do not know how to apply that knowledge with successful skill. That's what Madam was telling about applied anatomy. This we realize almost every day when we are operating. So this, when I was doing a laparoscopic polycystectomy, which is one of the very common surgery these days, up to the dissection, everything, we go to the callous triangle and then do a posterior dissection and clip the cystic artery and then clip the cystic duct. One of the areas in the anatomy, the anomalies are very, very common, is the hepatobiliary system. So biliary anatomy, whatever you know, many times there will be surprises. So this was one such patient who had no cystic duct. Gallbladder was directly joining the bile duct. So I had to modify my plan. I had to open and ensure that there is nothing stored behind, left out in that, and then put a stapler, do a stapler cholecystoplasty, and then remove the gallbladder. So if we don't have the proper anatomical knowledge, the disasters can occur. We might injure the bile duct, or we may abandon the surgery, or we may open up the abdomen and then again same thing, and thank God this everything went on well. Also, there are only about 16 such cases which are reported in the world literature, so we also report it. But Surgeon's Day is always challenging. Anatomy is very perfect. We should be the spleen, it's the stomach. In between, I was stuck one day. What happened? Doing a bariatric surgery, there was this harmonic scalpel we were using and dissecting, separating the stomach from the spleen because it was closely adherent, and then suddenly it hit me that it was massively bleeding there. So such things happen in surgeons' day again and again. If you panic, then it will cost your patient. We have to be very patient and take help, whoever is there nearby. All the surgeons sitting here know that such situations we not only take help from others, anesthetists, surgeons who are there in the other OT, and carefully use hemostatic plugs, and many times we may have to do a splenectomy also if the problem is more. Luckily, the bleeding stopped and I could continue my sleeve gastrectomy for a obese patient. So this is another case where we are doing laparoscopy for a perforation which is between the stomach and the jejunum, anastomotic ulcer after a bariatric surgery. So you have to properly recognize such things, maybe preoperative by the X-ray and all, and then close the perforation properly with a delayed absorbable suture. Here we have used the Vicryl suture. So anatomical knowledge, again very important, that you have to identify, that is, it is between the anastomosis of the stomach and the jejunum, and then close it properly. Sometimes if the momentum is not available, we may use the falciform ligament. Here luckily we could get some amount of momentum. So it's not that you close it and then put momentum. We have to close it over momentum because the momentum is the one which seals the perforation. So here I was using only 2 ports. So Dr. Preeti and other laparoscopic surgeons may be wondering why I am putting a clip there. That is, I was using only 2 ports. So closed the perforation, gave a good wash and put a drain, and that patient became alright. So every day we make use of what our anatomy teachers taught. This is the inguinal anatomy. Many of the students may not see because we dissect from outside. So this is the laparoscopic anatomy on the right side. You can see here this is the inguinal ligament of the iliopubic tract. This is anterior, posterior, and then here is the epigastric vessels. Here comes the iliac vessels. Here comes the femoral nerves and other nerves. So we call this as the different triangles. Indirect hernia triangle, direct. This is the femoral hernia, and this is the triangle of doom. Because for us to remember that if we injure any great vessels, that patient will not make it. So here there is a triangle of pain or quadrangular pain. If we use cautery or put a clip or tackers there, that patient will suffer lifelong with pain. So this anatomical knowledge, especially the laparoscopic anatomy knowledge, is very important to us. So that's why when we put our scope, we do inguinal hernia, we first look at the anatomical structures, the internal anatomy, you can see the vast difference there, the umbilical fold, the midline, we call it as median umbilical ligament in the center, and the medial umbilical cord, the obliterated vessels, and left side you see the indirect inguinal hernia. So every anatomical knowledge becomes very, very important when we do this surgery. So the hernia is getting reduced, indirect inguinal hernia. Then we start our dissection and put a mesh and then repair the hernia from inside laparoscopically. Robotic surgery is very surgeon friendly because you can sit on the console and then without troubling our back we can do our surgeries. So here again the robotics have come to our help. It is becoming more and more popular. The main strain is on the wrist and there is very good 3D imaging, and these are excellent for suturing and also dissection, both monopolar and bipolar cauteries. You can see the inferior epigastric vessel there, the hernia getting reduced, inguinal, the indirect sac, and then cord structures, and then put a mesh, and then close this with the absorbable sutures. So that is comfortable to do for the robotic surgery. But the bariatric surgery is a different ballgame where the patients come with BMI 90, 200, 250 kgs. This patient was airlifted from Qatar. So with multiple comorbidities, it is a teamwork. It cannot be done with one surgeon. We need a lot of help from others. The nutritionists, the radiologists, intensive care specialists, anesthetists, bariatric physician, everybody. And when we do either sleeve gastrectomy, gastric bypass, or one of the bariatric metabolic surgeries, the results are excellent. You can see this lady who was always panting to walk, and not able to do. Now she is a champion. She is a weightlifter, she is a marathon runner, and all her dreams in the life has come true after she shedding her weight and becoming a fit person. So the surgeons, when they do surgeries, so all surgeons here know that they will not be bothering about themselves. They bend, they twist, they burn their back, and poor ergonomics will put a lot of physical stress and injury. So how to prevent this and avoid this is to be fit. Fitness is very important. So that is another of my passion, where fit to fight, and it has started even during my army days that fit to fight is a must there. Otherwise, we develop what is known as the sarcopenia. That is the combination of progressive loss of lean body mass with associated functional impairment. The muscles become weak, the abdominal girth increases, the muscles, as you see here, the lean body mass in the sarcopenic fat accumulates, the muscles come with lot of body changes in them. So to prevent that, the best thing is the combination of different exercises. Yoga is the one which gives excellent flexibility and also tones up your body. Shirshasana is the king of all asanas, and that is excellent, but don't do alone, do under supervision. You have to put pressure not on your bones, cervical bones or anything. It is pressure should be, the weight should be borne by the muscles of the forearm and the arm and the wrist. And the other combination exercises, the muscles have to be toned up, cardio, respiratory fitness is very important. These are the things you can go wherever you are and do the push-ups or some weight bearing exercises. They will keep your muscle fit, whether you go for conference or holidays or wherever you are. That is very important to keep the body fit. Traveling is another passion of mine, which definitely is a great learning opportunity. Before traveling, better to do some research. Blogs and YouTubes are available, and exposure to different cultures and customs, adventure and exploration. And it's a good relaxation and builds relationships. So I visited many countries and imbibed a lot of values and culture from different places, whether it is Srinagar or the China or the Sydney. Machu Picchu is a beautiful place, and our own country, there are many places. Iceland is definitely worth visiting. Travel is to live. That's what the great traveler Hans Christian Andersen said. So travel is to live. It indicates that you are active, you are alive. Even during COVID time, we didn't stop travel. Satish Rao is here. He had joined us also. We have a travel group, even in the MMC classes also. Now it has become travel group 65 plus. So scuba diving is another great thing. When you have an opportunity, don't miss it. It is the knowledge of anatomy again. Here comes very important, not only anatomy, physiology also. Under the water, how to breathe with the oxygen, carrying the oxygen cylinder, and then it's a wonderful world which is under the sea. We think we are the great. If you consider the universe, we are just a small speck. Not even our children will remember us after some time. So don't waste your time. Travel a lot, and then trekking is another way of keeping yourself fit. There are different ways of trekking. You can select easy, moderate, and nowadays we are doing the high altitude trekking, and this is definitely a great way of keeping yourself fit. And trekking, the great thing is you can see the places which we never see either by flight or by roads or by sea or anything. See some of these, this is the Seven Sisters in Peru, the beautiful falls and Machu Picchu, all this we trekked in the Andes mountain, and by trekking you learn a lot. There is no age difference. You can trek alone also, you can challenge yourself, and it's many times it's a minimalistic living. So you become one along with nature. So while trekking, sometimes we have to do the river crossing, and many times it may not be possible to go to the other side. So these are the things you learn and enjoy. For all this, you have to be fit, and fitness becomes very important. Dr. Preeti is here. She is another fitness freak, and she enjoys trekking, traveling, and this is a balancing act in the Tawny River, in the Dandi. So just imagine if you are not fit enough, you have not know your anatomy, everything, then it is difficult to do these things. So swimming is another example of entire body exercise, and the muscles, that is, you must not say pectoralis major, tensor facial, all the muscles will be used when you are swimming, and it is an excellent way of relaxing and also going for fitness. Kilimanjaro, that is one of the highest peak in Africa, 19,341 feet. Another of our classmate called Dr. Swarnabha, she and her daughter had come, myself and my daughter Chandana. We trekked all the way to this top of the mountain. Very difficult for some areas. This is called the Paramka wall, and take help, and there are people who are going to guide us. And then night trekking, that's also a part of it. About 6 hours we have to trek because it is summer. In the daytime it's very, very hot, and the night time it is very, very cold. But the scene you get once you reach above is amazing, and all your tiredness goes off. When we reached, it was minus 10 to 15 degrees centigrade in the morning. We hoisted the national flag, and the peak reached morning 7:20 or so. So this is 19,341 feet. Just to remind you that the Mount Everest is about 29,000 feet. So oxygen levels are low, you can't stay there for long. And cooking, everybody gets amazed that is it your passion? Yes, because it is enjoyable, it is relaxing, and you can do everyday new experiments and new learning and different combinations. You have control over your own ingredients, fresh, wholesome food, and it is, as our Prime Minister says, Atmanirbhar. So friends and students, our passion, whether it is surgery or other things, that is our life. So celebrate your life. Don't waste even one day. For that, you have to keep your body fit. Our body is our identity. Out of 24 hours, at least 1 hour we should get for our fitness. Many people say, I don't have time. I say, if you don't have time here, you will get all the time when you go there. So that should not happen. We should get time here, now, when we want, and should do the body fitness. So the great anatomy professors, teachers and surgeons, students, anatomical knowledge is the basic foundation of the medical profession, and it's very, very relevant in a surgeon's professional practice. We have to get updated, otherwise we will get outdated. So we should not become outdated medical professionals. Good knowledge of anatomy is essential to understand our own body and also maintain good health. Leading a healthy life is very essential to pursue our passion. Otherwise, we will be left behind. Not only the medical professionals, even the general public should have also some knowledge of anatomy. When we were students, we used to conduct the exhibition for the public, where we used to educate the public about anatomy. Otherwise, this is what happens. So, some patients come and say, sir, I have kidney problem. And their kidney is there. So, that is the problem. Then we have to educate them about the kidney and what is there in the scrotum. So thank you very much for this great opportunity.